Would you like to learn how a primary platelet plug is formed and how the coagulation cascade works? It's coming up next. This is Raj
and Niya with your favorite USMLE channel, where we help you gain in-depth understanding of the high-yield USMLE topics and score phenomenal on the steps.
We're teaching medical content for all steps using our own personally crafted mind maps and algorithm that's going to make concepts stick.
What you can expect in our videos is a lot of integration, as well as getting a clinical perspective of what's truly important to learn.
Hope you enjoy this video.
Please subscribe to our channel if you haven't already, and hit the bell button to receive notifications once we upload new videos.
Thank you for watching. In order to understand how a mature platelet plug is formed, we need to know who the main players are. Number one, you have the platelets. Number two, you have the coagulation cascade. And number three, you have your endothelial cells. Before we embark on the journey of understanding how these three are connected, let's learn about them individually first. Firstly, platelets. Important points for you to remember are it has three receptors. What are the three receptors that the platelet contain? It's going to be called GP1B receptor, GP2B3A receptor, and ADP receptor. And then you have two types of granules. Number one is alpha granule and the other one is the dense granule. What does the alpha granules contain? It contains 1 Willebrand factor and fibrinogen. And what does the dense granules contain? It contains ADP and calcium. Alright, we're going to use these players later on in the next video when the primary platelet plug is being formed. The second players who you need to form a mature platelet plug are the coagulation factors. So I want you to look at this. I'm going to get in depth as in the video to follow, but for now I want you to remember this is what your coagulation cascade looks like. It has an intrinsic pathway and it has an extrinsic pathway. Eventually your goal is to form factor 1, which is going to be called fibrin mesh, meaning your mature clot. Alright, and again I also want to kind of recall and make you remember what the vitamin K dependent clotting factors are. The vitamin K dependent clotting factors are 2, 7, 9, 10 and protein C and protein S. And remember, 2, 7, 9, 10 are procoagulants, they form clots, whereas protein C and S are anticoagulants, they break down clots. Your third important player in formation of your primary platelet plug is going to be your endothelial cells, because you're not going to form a clot unless you damage these endothelial cells. The endothelial cells also have some important substances which are involved in formation of a primary platelet plug, which will be explained shortly. So let's begin. In order for us to form a primary platelet plug or a final clot, you must damage an endothelial cell. So here I want you to focus on my diagram that you see this in red are your endothelial cells. So first of all, you need to have tissue injury. Moment you have tissue injury, that is the trigger for you to actually start formation of your clot. So first step is exposure of subendothelial collagen. Now what binds to subendothelial collagen? Okay, let's think about it. It's the 1 Willebrand factor. Where does 1 Willebrand factor come from? I've already given you one place where it comes from, which is your alpha granules. Alright, but the alpha granules won't just simply release 1 Willebrand factor until the platelet's actually been invited to the party. The platelet has not even showed up yet. So where does it come from? Where is the initial 1 Willebrand factor coming from? That is a hot topic right here. So 1 Willebrand factor comes from your endothelial cells itself, which is from a certain type of body known as Weibel-Palade bodies. Alright, it is known as Weibel-Palade bodies. In your endothelial cells, that's going to release 1 Willebrand factor. Alright, so that's your first step. 1 Willebrand factor is released, it attaches to subendothelial collagen. Now, in order for you to form the platelet plug, obviously you're going to need the platelet. But how does a platelet attach to the 1 Willebrand factor? Well, as I told you, it's got two receptors. So let's take the first receptor that we need. The first receptor that we have is GP1B. Back in the day it was called GP1B, but recently they have changed the name to GP1B95. Alright, GP1B95. The function is exactly the same, it's just that the name has been slightly changed. Alright, so the platelet comes here and binds to the 1 Willebrand factor via GP1B receptor. This step is known as adhesion. This could be a step 1 question where they'll ask you what is this step called. This is known as adhesion. Alright, once your platelet attaches to this thing, right, once it attaches to the 1 Willebrand factor, next step is it has to activate itself. How does it activate itself? It releases a certain substance which is going to be called ADP, adenosine diphosphate. So the ADP is released from the platelet, from which granule again? Yes, it is from your dense granule. Alright, so ADP is released and ADP binds to self receptors known as Adp receptors. This is the other third receptor which I did not mention about before. Again, I want you to remember the rule of 2 and just remember an additional Adp receptor as it on the side. Alright, so the ADP binds to the Adp receptor. Once that happens, automatically now your platelet gets activated. Alright, once it gets activated, it's going to express another important receptor which is going to be called your GP2B3A receptor. Now this receptor is so important because this is the receptor that attaches multiple platelets together by means of a small molecule which is known as fibrinogen. Alright, fibrinogen is basically going to attach the two platelets together. But does fibrinogen mean it is a final product? Absolutely not. In order for you to have a final product such as a mature clot, you need fibrin, not fibrinogen but fibrin. Now what converts fibrinogen to fibrin? Oh, let's think about it. Okay, you need something known as thrombin, isn't it? Thrombin is clotting factor and thrombin is factor 2. As you see up here, clotting factor, factor 2. This is what you need. So how do you bring about factor 2 in order to convert your fibrinogen to fibrin? This is the important link that I'm going to give you that's going to tie everything together. Let's go back. Let's rewind a bit and get back to the very beginning. At the very beginning, when we damage our endothelial cells, what happened? You expose subendothelial collagen. Does the subendothelial collagen have another function apart from formation of platelet plug? Absolutely yes. The subendothelial collagen is going to activate your factor 12 directly. It's going to activate your factor 12 and kickstart your intrinsic pathway of your coagulation cascade. Alright? And what about your extrinsic pathway then? Yes, that also is kick-started initially, but not by subendothelial collagen, but by something else which is known as tissue factor. Tissue factor, also known as thromboplastin. Alright, tissue factor or thromboplastin is present, it is released the moment you damage an endothelial cell, and the thromboplastin is going to go and activate your factor 7. There you go. This is the key connection between your platelet plug formation and your coagulation cascade. They both happen at the same time. They have to work together in order to get your final product, which is your mature clot. Alright, so once you activate factor 12 and factor 7 from here, you're going to start, your coagulation cascade is activated, and eventually you're going to form factor 2, which is going to be thrombin. And now thrombin is what's going to convert your fibrinogen molecule to a fibrin mesh. Alright, you need to go from fibrinogen to a fibrin mesh. Now, is it only factor 2 that you need in order to convert from fibrinogen to a fibrin mesh? No, you need factor 2, but also you need factor 13, which is known as the glue. Alright, so with the presence of factor 2 and factor 13, here you go. Now you got your final product, which is your fibrin mesh, and a final clot is actually formed. Let me ask you guys a question. Now you've learned about how you could form a mature platelet plug. Alright, so what would happen if we mess up with any of these steps? Would you have more clot formation or would you have more bleeding? Well, this is to form a clot. So if you mess anything up in these steps, you will end up getting more bleeding. So let's do that. Let's go back to the beginning and we'll see what we can mess up, maybe genetically, maybe by giving medications, or maybe in an autoimmune way. All right, but that's what we are going to do. We are going to learn about multiple different conditions that are tied up to this same pathway. So let's go back to the beginning. All right, now when you go back to the beginning, we damage the endothelial cells. You expose subendothelial collagen. The first step is the binding of 1 Willebrand factor. Okay, there we go. That's a pit stop right there. 1 Willebrand factor. What if you have a lack of 1 Willebrand factor? What disease would you get? Yes, you're absolutely correct. It is 1 Willebrand's disease. Alright, 1 Willebrand disease is a condition where you're going to have a lot of bleeding. Okay, now I'm not going to go into the subject proper. I will cover that in a different section, but for now I'm just going to give you some fun facts with regards to these conditions. 1 Willebrand's disease, you often give them a treatment which is known as desmopressin. Desmopressin sounds a lot like vasopressin. What does desmopressin do is it actually stimulates these viable Palladi bodies in your endothelial cells to release 1 Willebrand's factor. So just remember this cool fact for now. Next, let's keep moving on. So what attached to 1 Willebrand factor from your platelet? It was GP1B, previously now known as GP1B95. Alright, good. So what if you had a deficiency of this receptor genetically? Is there a condition which they like to question us on? Yes, there is. It is known as Bernard-Solier. And the good part is that it's GP1B, B for Bernard-Solier. That's how I remember it. I think it's kind of easy to remember it that way also. Alright, so once you bind with GP1B, what's the next step? Release of ADP. Alright, so ADP binds to self-receptors known as Adp receptors. Now I'm going to throw in a couple of medication that actually blocks this Adp receptor. And these medication actually are called P2Y12 inhibitors. All right, and these medications that actually block these ADP receptors are clopidogrel, prasugrel, and ticagrelor. All right, clopidogrel was the first generation. Now the newer ones are the prasugrel and ticagrelor. Okay, let me ask you this. Where do you use these medications? Well, you want to use this medication in some place where you don't want your platelets to form any form of clots. You kind of want to prevent them from doing that job, right? So who would you use this medication on? Well, think about it. If somebody comes with a chest pain and ends up getting a drug-eluting stent or a bare metal stent, what medication do you put them on? Aspirin plus clopidogrel, aspirin plus prasugrel, or aspirin plus ticagrelor. What is the point of putting it? The idea behind these two medication is you want to prevent the platelets from aggregating to each other so that the stent does not close. Alright, so now you know the mechanism of action of how these three medications are working. Everything's connected, guys. You got to think of it in the large scheme of things. Alright, so let's keep moving. Alright, so at Adp receptor we have three medication and you know how it works. Okay, so what's the next step? Once Adp binds to the receptor, next step is exposure of GP2B3A receptors. Wait a second. What if you genetically lacked GP2B3A receptors? It's a really long name also, right? GP2B3A receptor. Well, there is a condition. It's going to be called Glanzmann's thrombasthenia. Okay, Glanzmann's thrombasthenia. So again, I will be covering this topic separately, but for now I just want to remember that Glanzmann's thrombasthenia is the lack of GP2B3A receptor genetically. Alright, now do we have a condition where there is autoantibodies against GP2B3A receptor? Wait a second, yes there is. It is ITP. ITP is a condition. It's known as Idiopathic Thrombocytopenic Purpura, but you have autoantibodies against your GP2B3A receptor. So you got to tie this up here as well. Okay, what about medications? What if we came up with some medications to actually block this receptor? Yes, have we done that? Yes, we have. What are those medications? You have medication known as abciximab, tirofiban, and epinephrine. Aptifibitide. All right, these three medications are basically made in order to block the GP2B3 receptors. Where are they used? Again, it is used in patients who are coming with coronary artery disease, with chest pain, and end up going for a angiographic procedure and the stents put in. Oftentimes the cardiologist will be using this medication while doing this procedure. So you don't have to know so much about it. Just remember that these medications exist and they're oftentimes used in patients while they're getting the angiography. All right. Okay. We're done with GP2B3A receptor. Now let's go back to your platelets. I want to ask you a question. If somebody had kidney dysfunction and the kidneys are not functioning, and are they prone to bleeding? Yes, they are. A lot of books tells you, oh, it's platelet degranulation problem. When there's uremia because of kidney dysfunction, you will have something known as degranulation problem. So think about it. Trace back your granules. If you do not degranulate and release your substances present in the platelet granules, could you have a lot of bleeding? Yes, you could, obviously, right? So that's the other condition I want you to remember. Uremia basically is going to prevent your alpha and your dense granule from releasing their good stuff within. Therefore, you will not form a platelet plug. Alright guys, so I think this basically ties up everything that you need to know in regards to the platelet plug formation and your coagulation cascade and how all of this is tied up together. You will see that we are going to cover the same topics in different lectures. That way everything's going to come together. But for now, this is your big mind map. You must remember this map and open up and add more stuff to it as you go along. We are done with talking about the platelet little tweaks that we could do and result in diseases and medications that we have already learned about. Now let's just, for a couple of additional points, I want you to focus on your coagulation cascade. Do we have conditions and medications that we could tweak this pathway and end up with a disease or some form of result because of it? Okay, so when you think about it here, I want you to focus on this factor 8. If you do not have factor 8, what condition would you get? You would get something known as hemophilia A. Very good. And if you do not have factor 9, what condition would you get? You would get hemophilia B. If you do not have factor 11, you would get hemophilia C. All right. Now, next important thing I also want you to focus on is factors 2, 7, 9, 10, and then separately we'll discuss about protein C and protein S. But factors 2, 7, 9, 10, what are these? These are vitamin K dependent coagulation factors. Okay, now vitamin K dependent coagulation factors are actually produced in the liver, but they need vitamin K to get activated. Who produces vitamin K? Your gut flora. What kind of vitamin K does your gut flora produce? K2. It gets converted to K1 and K1 gets absorbed into your bloodstream and eventually is used by these clotting factors to become active. So for whatever reason you do not have vitamin K, you will have excessive bleeding because of the factors 2, 7, 9 and 10 not being able to function properly. Okay, so what would cause a vitamin K deficiency? Well, think about it. If you do not have gut flora, if somebody's on a lot of antibiotics for a very long time, they could have that problem. If somebody has Crohn's disease, they could have the problem. If somebody has celiac disease, they could also have that problem. There's so many other conditions, but the bottom line is, if you do not have vitamin K, you will have an increased risk of bleeding. Okay, and what about medications? Do we use medications that actually affect these factors 2, 7, 9 and 10? Yes, there is. It is known as warfarin. Okay, warfarin is basically gonna affect the function of 2, 7, 9 and 10. It does not really cause a deficiency of vitamin K, but it actually blocks a certain step known as gamma carboxylation of these factors, and it blocks an enzyme known as epoxide reductase. Again, we will discuss this in a different section, but for now I want you to remember that vitamin K dependent clotting factors are inhibited by warfarin. Okay, all right. And I think that's about it. This ties a lot of conditions together, and I hope you guys enjoy this video, and I'll see you on the next lecture. Thank you.